Dear colleagues, welcome to this session sponsored by Inari Medical, entitled Why Mechanical Thrombectomy Should Be Considered in Management of Acute Pulmonary Embolism. So I'm sure you and we all already experienced this kind of frustrating clinical situation in the ICU. We have patients coming in the ICU. We decided to give antithrombotic strategy according to the risk of the patient. It can be lytics or heparin only, depending on the patient and contraindication to lytics or not. And usually the next step that we decide within the ERT team is to see and to hope that the patient will improve in the coming hours. And honestly, that's not exactly what we want as interventional cardiologists. So we just have to have in mind what happened for other life-threatening events, where for STEMI and for stroke, we move from drug-only management to pharmacoinvasive approach. For the STEMI, it was the primary PCI more than 3 decades ago. And for the stroke, it's more 10 years ago that we start the thrombectomy. And both clearly improve the clinical prognostic of these two acute events. So maybe the next one on the list could be the pulmonary embolism, where we can go from just antithrombotic strategy and lytics in some selected case with indication and no contraindications, but probably to use a pharmacoinvasive approach. So that will be the idea of the presentation, is to discuss whether we will move in the coming months, year, but we already do in our center this kind of approach. And accordingly, first, because I think we are quite lucky in interventional cardiology to base our practice on evidence. So first, we will discuss the available evidence for the use of mechanical thrombectomy in this clinical situation, and we will also see what will be the upcoming evidence. Then we will, thanks to case-based presentation, to appreciate patient profiles who benefit from this mechanical thrombectomy. And finally, just to think as a team and to see how you can implement that in your hospital and in your local network, to see how we can integrate this technique in your local PE patient pathway. So to do so, you have beautiful pictures on the screen, but you have even better faces on the stage. And as you can see, and just to share with you before starting directly the session, the flow of the session. So to set the stage, Felix will first discuss the clinical evidence available today and coming next. And after, we'll have two cases presented by Gregor and Katalin, one with intermediate high-risk pulmonary embolism and one with high-risk pulmonary embolism. And after that, we will discuss together how to assess eligibility for mechanical thrombectomy and how to implement that in your local network. And you will see that Pablo will propose the algorithm that they use in Madrid, and that will be a good moment to discuss and to see how we can organize that. So I think without further introduction, it's my great pleasure to invite Felix, who will give you an update about the clinical evidence for mechanical thrombectomy.
Thank you, Thomas. It's great to be with you, and I can tell you also that I'm very pleased to see another packed room. So that also answers the question on whether this is relevant to the interventional community. I think it is, and this is why we're building that program too. And you'll see much more in the next editions of PCR and EuroPCR, I'm sure. So in the next couple of minutes, what I'll try to set the stage a bit about what is known about mechanical thrombectomy, which data are available, and what should we consider indeed when talking about it. Randomized controlled trials are ongoing, and you'll see at the very end of my presentation which two important studies are ongoing right now. But what can we base our decision-making in the meantime on? And here the FLASH registry is of utmost importance, and this is being run by Katalin Thoma, who's with us from the United States. This is a prospective multicenter single-arm registry, initially designed in the US only. Then we were lucky enough to include another 200 European patients into that registry. This is completed. I'll show you a few preliminary data in a second. But the overall objective of this registry is to evaluate the safety and effectiveness of the FlowTriever system for treatment of PE in an all-comer patient population. Registry mainly focus on safety, of course, which is then here also the primary endpoint, major adverse event, a composite endpoint consisting of device-related mortality and major bleeding within 2 days post-treatment, and intra-procedure device and procedure-related adverse events. And then you would see a couple of functional assessment post-procedure that are also being captured in the registry, such as RV size and function, symptomatology assessed by a dyspnea scores, 6-minute walking distance, and quality of life. Few aspects that I wanted to highlight from the first 800 patients included in the registry, published by Katalin Thoma in Eurointervention 1.5 years ago. You can see here that 65% of the patients had concomitant DVT. Very few patients had a systolic pulmonary arterial pressure above 70. That's something you'll hear more about during the session, I'm sure, because we use this as a cutoff on to decide whether we're turning more into a chronic situation where probably thrombectomy is not the best approach to move forward. Lytic contraindication, certainly something of relevance for decision making. 1 out of 3 patients in the registry here had a contraindication to systemic thrombolysis. A small proportion of patients at high risk, that's interesting. I found it interesting, at least when looking at the data for the first time, because I expected the number to be much higher. But obviously in the US, most patients that are treated are indeed at intermediate high risk. The safety is excellent. You have to keep in mind, though, that these were highly trained interventionists who did the procedures. Most of the centers had a PER team installed in the decision-making process. So I think, in highly experienced centers, indeed, the event rate was very low, 1.8%, 48-hour major adverse event rate, no death, no pulmonary injuries, no cardiac injuries that were related to the procedure. And when looking into functional improvements post-procedure, you can see that the RV-LV ratio, which is still an accepted endpoint by the US FDA for approval, significantly improved post-procedure. Something that you will recognize very shortly when you start a program is that this procedure improves hemodynamics very quickly. Post-procedure, once you have removed the clot in most patients, you do see significant changes in pulmonary arterial pressure. The mean here was 18 millimeters of mercury for systolic pulp, and cardiac index improved by 0.3 liter per minute. This is preliminary data. I mentioned that the 200 patients out of Europe have been completed. The subset of patients is being analyzed now and will hopefully be presented again at ESC as a full cohort. This is just a glimpse into the data that I presented last year at ESC. And there are a few aspects that are relevant, I think, for the European community because we can learn from this. It's interesting to look into the differences. Here in Europe, 40% of the patients who were included in the registry and treated with thrombectomy were at high risk. Recap, it was 8% in the US registry. Here we're talking about 40% of patients. 1 out of 4 patients presented with a contraindication to thrombolysis. Procedural details pretty much in line with which has been presented. 35 minutes was the thrombectomy time. And interestingly enough, I think that's important for resource management as well. 60% of the patients did not require an overnight stay on the intensive care unit post-procedure. Exactly as in the US cohort, we do see significant improvements in hemodynamics. Mean arterial pulmonary pressure decreased by 23%. RV-LV ratio improved by 30%. And despite the fact that we have included 40% of patients at high risk, you see very low major adverse event rates, 1.8%, and this is certainly of interest. And, it gives hope that indeed this procedure improves not only hemodynamics, but also outcomes in patients presenting with acute pulmonary embolism. Symptoms also improved in those European patients quite significantly. And when looking into heart rate as a surrogate of an improvement in hemodynamic status during the procedure, you'll see that in the European cohort there were 15 beats per minute acute reduction in heart rate from pre-procedure to 48 hours. Which evidence is also available, and I'm sure we'll discuss it here. This is the FLAME study, a very different entity that has been treated here. So this study focused on patients presenting with high-risk PE, so a really sick patient population. And this study was not randomized, and this figure is not intended to suggest it was randomized, but it shows that there were patients treated with the FlowTriever arm, there were patients put in the context arm, and there was an historical control established from the PERT registry. The primary endpoint here, again, was an in-hospital composite looking into all-cause mortality, bailout to alternative thrombus removal strategies, clinical deterioration, and major bleeding. And using historical data, primary endpoint assumptions were made, and you can see that the performance goal was set at 32%. So given the presentation of patients in the database of the PERT registry, indeed it was expected that 32% of the patients would present with this primary endpoint. So this was set as the performance goal and agreed upon with the FDA. After 50 patients have been included, indeed the study was stopped because the FlowTriever arm did quite well in this registry. So looking into the composite primary endpoint, again 17% was what we saw in FLAME, and this is much lower, almost half of what has been expected and set as the performance goal in this study. The context arm, although the comparison lacks a little because it was not randomized, but again, in the context arm where the physician decided I'll not opt for thrombectomy, the primary composite endpoint reached indeed 64%. In-hospital mortality quite low, 1.9% in the FlowTriever arm. The performance goal was 28%, so significantly lower than expected, and pretty much in line what happened in the context arm. Where are we heading next? And I think it's very, very important to reiterate that we're still waiting for randomized controlled trials to be completed and to provide solid evidence that indeed this technology not only improves hemodynamic but also outcomes. There's one study ongoing which is called PEERLESS, 500 patients being randomized to thrombolysis, catheter-directed thrombolysis, as compared to mechanical thrombectomy. This study is ongoing in the United States and in Europe, and we'll hear more about it during the discussion, I guess. And another study, which I think is even more important than PEERLESS-1, is not the comparison of a device against another device, but this is a device, which is mechanical thrombectomy, against standard of care. And this is guideline relevant because here we're investigating a new treatment path, a new approach to patients, and compare it to standard therapy. And this is PEERLESS-2. You'll see here the primary endpoint and a win ratio, quite important endpoints put together in this hierarchical analysis. And it will be the largest trial in device-based PE treatment, among the largest trials in PE overall. 1,200 patients randomized 1-to-1 to FlowTriever and conservative therapy. The study is just starting, so we're looking for sites indeed. And if you're interested, of course, approach the company, approach the steering committee, and we're very happy to facilitate that process as well. So thank you very much for listening. This is just the start of this session, a start of this therapy, and I look very much forward to your questions now. Thank you.
Yeah, thank you, Felix. Indeed, I think it's really important to see the evidence before discussing cases. Just to tell you, if you want to comment or to ask a question, you have microphone in the room, and also you still have the online system to send us your question that we will address.
May I ask a quick question?
Of course.
So, thank you, Felix. Was there a difference between the European versus the US patients? I imagine the US patient is a big BMI man with huge vessels, and you have to have a big Inari device to get this out.
We not only treated lean women in Europe with thrombectomy, right, as you know very well. So I think, of course, there are differences, right? Do they explain the differences in outcomes? No, I don't think so, right? And I don't think that they explain the utilization difference. What for me was striking is really to look into the proportion of patients with high risk being treated, right? And this also reflects we're a little more mature here in Europe as compared to the US, where this is really standard, also because of reimbursement issues, I guess. But we're starting, and I think it's good to start with patients at high risk. We discussed it a lot, right? How to set up a program. But starting with high-risk patients is rewarding because you see improvements in hemodynamics and you really see that the patients are doing better afterwards. And despite the fact, again, just to reiterate what I was saying, 40% high-risk patients, major adverse event rate was quite low. So that is suggestive of an improvement of outcomes as well.
Yeah, and it's not that we're not treating high-risk patients in the U.S. It's just the fact that we're treating a lot of intermediate-risk patients as well. And I think that's the main difference. And this concept is how do you start the program is, cuts both ways, right? Because you want to have a more stable patient at the beginning. This is a new field for everybody. We learned this along the way. And I think there's a lot of physicians who, start programs, but they don't know much about the pulmonary space, about, the disease state itself even sometimes. So that learning process, do you do that, in a fire drill type of scenario where you have to perform and save somebody's life, or you do it in a more sort of stable, and I'm not talking about, low intermediate risk. I'm talking about high intermediates that are close to decompensating. So I think it's a balance of both, to be honest with you. It depends on the local skills, and so.
Yeah, that was exactly my point, that when we start, we also start with more intermediate high-risk patients, because indeed, when you start with new technique and to align the team and to take time, to organize the first case, when usually you need the assistance of the company who come to proctor us, I think intermediate setting was probably an easier one. Maybe one question for you, Felix, regarding the ongoing studies. PLS will compare the thrombectomy, which let's say it's mainly for proximal ones, and the catheter-based thrombolysis, which is probably more effective, for the diffuse and distal one. Do you think it's a fair comparison, or don't you think it's exactly the same type of PE that should be treated by either devices?
So you suggest that there's a difference between the two devices on where the thrombus is located, which we don't know, right? No. We think it may be, but we don't know. So this study, for me, is not answering a very important question, because I don't think that, there is equipoise, that one device has to be tested against another device, which is why we were pushing quite hard. And I'm happy that Inari took the advice to run a study to compare it not against another investigational product in Europe, but to test it against standard of care. That is what we want to know. We want to know whether doing a device-based procedure improves outcomes as compared to standard therapy. And I think we can easily agree that standard therapy in those patients is anticoagulation or thrombolysis, not another device. So that's probably the overall objective, which I think that study will really answer an important question.
So you mean before comparing the device, let's prove that we need the device?
Absolutely, yes. And also it will help us, because we were talking on the higher threshold for taking the patients to the cath lab, which is high risk, but also this will translate some information into the patient selection. So by using the patient selection criteria that Peerless 2 is going to use, we will have the lower threshold on which patients can be have benefit from the therapy, contrary to some patients, for example, with just have massive PE, which is low, some patients with low risk PE that might be overtreated. It's not that it's a bad thing to happen, but maybe you can skip the therapy on the lower end and maybe put more efforts into treating every patient in the right way, meaning mechanical thrombectomy for the higher end of intermediate to high risk.
Again, feel free, please, to stand. We don't want a panel discussion for this session. So we will love and would like to hear from you, and you ask any question you can have in mind. But I think when we will discuss cases now, it will be easier just to share and to interact. Yes, you have a question there? Please. No, you just raise your hand to say there is a free seat. Sorry. Yeah, Gregor, please.
Add one comment. And it's also, I think, going the whole way, because the other device therapy that is used or tested against in PLS is still using 50% of lytics. So, and we have observed, although lower, but we have seen patients with intracranial hemorrhage on that lower dose. So I think it's also reasonable to go all the way and be completely lytic-free, as you alluded, as we've done it in STEMI years ago, and we've done it also in stroke. Now it's time for PE.
It's true that for STEMI, when we try to give both the potent drugs and the intervention as well, finally we fail. So that's exactly... Yeah, please, can you use the mic? Otherwise, nobody will hear you.
Maybe this is an early question, but what is the difference of the price between the thrombolytic arm and the mechanical? Average.
I can tell you in my country, which is Spain, but it might be different in other countries. So echoes, you normally will treat a bilateral PE, which is 80–90% of the cases, so you will use 2 catheters. That would be 5,000 euros, and in ARI is 8,000 euros. It's a fair question. It's a fair question. I think it's okay we discuss these kind of things. Yeah.
However, the ECHOS guy or person is on the ICU. That's 1,500 Swiss francs in my country. And the flow retriever person, as we've seen in the data you presented, has a higher likeliness of not going to the ICU, can go on the ward. That's about 700 Swiss francs. So we also have to consider that.
Indirect costs as well that has to be taken into account, yes.
And then intracranial hemorrhage and the whole rehab is also very expensive and also very bad for the patients, although these are low numbers. So I think it's not just comparing 2 devices, the price for 2 devices, which can also change in the future as well.
For the whole patient journey. So probably, Gregor, you can now go and present the first case, which will be focusing on a patient with intermediate high-risk pulmonary embolism.
Yes, so thank you very much. It's a pleasure to be able to present this intermediate high-risk pulmonary embolism patient that was treated with a flow retriever. We also started with intermediate high because another hospital in Switzerland started with high risk, and I learned that they used almost in all cases hemodynamic support and a huge team behind, and they also lost a couple of patients. So we thought it's a little bit safer to start with the ones that are just at the cusp of getting or becoming hemodynamically unstable. So huge benefit, hopefully, but not as bad into the mechanical deterioration of the right ventricle. So we also talked about the risk stratification, and if you look at the ESC guidelines 2019, you can appreciate that there is low, intermediate, and high risk, and in the intermediate there is intermediate high. When you look at the criteria between intermediate high and high, the difference is only that this patient is in shock, and this was our impression that this may complicate the procedure in the beginning, and we really wanted to have great success and get over the learning curve until we treat the more severe patients. So this was a 56-year-old male. He woke up with dyspnea, then presented to the emergency department. CT scan was done. You can appreciate the ECG, which nicely shows a Q3S1 type, but this is very non-specific. It's about 50 to 60% sensitivity. So CT scan is gold standard, as you all know, and there we found this large thrombus, central, paracentral, segmental pulmonary embolism. And what you can also diagnose, and this is very important because it's fast, it's with the same exam, is the RV dilatation. So the RV-LV ratio was way over 1, indicating RV dilatation. The same was true in the transthoracic echo. We usually do it because you can assess other things if the patient has valvular issues, and also the left ventricular function, but it's not really needed for the diagnosis of the thrombus in the pulmonary, which is central, which is addressable by thrombus aspiration. And of course, a patient was intermediate high risk given the troponin levels. this is all the tools, and every day there's another edition by Inari. They always ask me, do you have the new one? And I think, which new one? The one from last week or next week? So it's really, really helpful that Inari is bringing out a lot of these tools and also improving them constantly. There is, for example, one of those aspiration catheters that has a curve, so we can go inwards on the mostly outer curved left pulmonary artery. They're reducing those discs that you see and replacing it with just one, so it makes disc selection much more easier, and they also have some stasis tools, so it's very, very handy. And I'm sure we're going to hear a little bit about flow saver in the second case, which was intermediate, which was a high risk. So here you can the CT scan, and if you just look at the interesting part, you can appreciate that there is large thrombus burden, not a saddle thrombus, and also not a central, but paracentral, and almost completely occluding the pulmonary artery. And you can also appreciate on the run that the right ventricle was obviously dilated. So this was the echo, same thing. And then I'm sure you're eager to see the procedure. And here I have a few pictures. So you do a femoral puncture, you introduce the Inari sheet, and then you advance a wire. Different catheters are used to go through the tricuspid valve in the pulmonary artery. We usually is recommended to start on the right side because that's more difficult to wire. And if you have the big catheter in and you pull it back, it will jump over to the left side. So we always start on the right side. And usually also we get more thrombus burden on that side. So you can use different catheters. You put the J-wire in, then you advance a multi-purpose, you go very distal, then you retrieve your J-wire and you introduce Amplatz super stiff, straight, and it only has 1 millimeter of floppy tip, which is a little bit dangerous. Here you can appreciate it. This is floppy, the rest is super stiff. This is what is needed for this huge catheter, which is the T24, 24 French. There's 20 and a 16 that can be used as a telescope or to go more distal if you believe that you need to get thrombus from a more distal branch. So what you do is you put the wire in and you don't stick it out because you can perforate the periphery. We just retrieve your guide, your multipurpose, and then you advance your flow retriever and you put it in that place, and then you can inject either over a flow retriever or previously, as you used to do it over a pigtail, and you can, unfortunately it doesn't run, but you can appreciate that there is a huge defect of contrast here, and there is the upper lobe, the mid, and on this carina here, the thrombus is actually sitting. Remember, the thrombus comes from the leg, so it's a long worm of coagulated blood, and it will eventually slurry in the pulmonary and then usually flung over a bifurcation and then sit there. This is very, very often the case. So again, here you can see the injection. This time is live, and you can see the defect here and there. If you're lucky to have a mapping software installed on your software, you can also do mapping and do it this way. But this is the way we do it in Basel. I think it's quite easy to locate the thrombus. Then you place the guide, the flow retriever right in front of the thrombus. Don't go inside the thrombus because you need actually a little bit suction of the blood and then engaging the bloodstream, and then it will suck out the thrombus. In this case, the thrombus was so dense that we couldn't aspirate it, so we went up with the wire, microcatheter, and I proved that there is distal flow, and then we could direct the flow retriever a little bit more towards the thrombus and then aspirate it, and then take it out. And when you inject again, you can appreciate that the complete upper lobe is free and flowing, and might be some residual thrombus here and some down there. So you redirect again with the safe J-wire, and then you can aspirate from other locations. Once you're happy on one side, you flip over to the other. As said, you just pull back, and usually because the trajectory is much more straight, goes to the other side. Then you can demonstrate that there is thrombus. You can orientate your flow retriever. Here you can imagine that the curved one is really handy because it curves inwards and the thrombus is right here, so you're better accessible. and then you aspirate from there. You can do more checks, and sometimes you get stuck, so nothing is coming in. We call this a lollipop. The idea is that the thrombus sticks on the tube and it doesn't go in. Also needs time for the soft, gooey thrombus to actually massage it into that tube. And then sometimes you pull back and you really feel like it's hanging onto something. It's like you go fishing on the weekend. And then you pull, and then all of a sudden the thrombus might come in and you can aspirate it. Then you inject contrast again, and you can see there's residual thrombus. I think this is either old thrombus from previous or fresh adherent that can be addressed by anticoagulation later. What we want is to restore flow in all peripheries and reduce the resistance and therefore the pulmonary pressure and afterload on the right ventricle. Here I had to prove again with the microcatheter, and you can see that there is proximal thrombus obstructing the distality, so I was sure that I have to aspirate again, and then it was improved, and this is how you go through the step. Again, on the right side, so all the thrombus was removed, and this is how it's presented by Inari. I think it's a very nice way to quantify the thrombus. Of course, it's not true. The lungs are three-dimensional. This is flat. But if you do all the same, you can compare between patients. And you can also appreciate how remarkably the blood pressure reduction, therefore the afterload reduction was. And I think the best indication is increase in oxygen saturation and decrease in heart rate. And this is how it looks when you collect all these pictures. Maybe Panini is going to do an album in the future, but that's how we collect them. And I think overall it's really nice to compare where the thrombus is coming from, and you know the case, and you know see the thrombus load, and you can appreciate how much you have to aspirate. And we learned very much with those images. These are our data, 47 so far. It really basically copies what the presented data says. And this is our practice, but we will hear more about in the other case, so I skipped that for the sake of time. My conclusion is catheter-directed thrombectomy is feasible, safe in intermediate high-risk patients. Immediate reduction of pulmonary pressure, heart rate, and increase in oxygen saturation is very frequent. Normalization of RV size and function is usually seen in our cohort in 24 hours. And it may translate to lower morbidity and mortality in these patients. And this is what we all hope, of course. I want to leave you. Thank you very much.
Thank you, Gregor. Beautiful example of how effective it can be. Do you have any question? Yes, please. Yeah.
Thank you. Thank you, Gregor. I'm here. I was wondering whether you had used the 16 French aspiration device in between, because your sheath tip was like a centimeter or more away from the most proximal clot. You know, I've experienced you really have to touch the clot to get it out. Maybe Katalin wants to also comment on this. Did you have an in between that it wasn't shown? That's my question.
I was not using the 16 because it reduces your lumen from 24 to 16, and that is really important. The flow that you can generate and actually the success and the amount of thrombus that you can take out is exponential to the diameter. So if you reduce it by 1 millimeter, you're losing a lot of aspiration capacity. And this, I think, was the main reason why all catheter-directed thromboaspiration devices failed in the past, because they're just too small. And when you put up the flow trigger for the first time and you see it coming up on the diaphragm, you're a little bit worried as an interventional cardiologist only doing right heart catheter with the Swan guns before. But it's quite safe, it works, and that's why I did not change to the 16. What I actually did there is I introduced the dilator again and I moved forward again, but I didn't want to show all the steps, and then I removed and I was a little bit closer. However, last comment, I think if you really touch the thrombus, you don't generate that suction. It's like when you vacuum at home and you put your vacuum on the carpet and you start the vacuum cleaner, nothing's going to happen. But if you go a little bit from the distance and you go closer, you feel that flow. It's generated and it's sped up, and then it can actually take out the thrombus from the periphery. So I'm a little bit in front, not as much as you've seen here, but not inside the thrombus.
Yeah, I mean, just a quick one on the 16. I think you use it very rarely in a segmental type of situation. So if you have clot in A10 or some big segmental, then you do the 16. What made a big difference, and it's not shown in this case, is the T20 curve that allows you to go deeper on the left side in particular and get to this clot.
So the actual aspiration point was deeper than what was shown, right? That's what I mean, because
absolutely.
people may think I aspirate here and
No,
it
no,
comes,
no.
comes up from the bottom.
But this happens too. I've aspirated at this spot, and then when I check, the thrombus down in the lower lobe was gone. This can happen.
Yes.
So Inari at least tells me, go back out. You're in the thrombus, and that's what they suggest. And I couldn't believe it at first because I thought you have to be there because I want to grab this part. But I think it's really increased flow when you aspirate first blood and then the thrombus gets sucked out. But it was closer.
Two questions from the audience. One is how to navigate to the distal artery to check that there is distal flow. And the second one, how to manage blood loss during the 24 French.
Okay, usually this was an advanced case, a little bit further in our experience, so we were more easy to go distal with the wire and wire this, and also was really hard thrombus. I couldn't aspirate, so I wanted to know a little bit more the distality. But usually it's not recommended. You do a proximal pulmonary angiogram, and then you go from proximal to distal, and you don't go past the thrombus. Also, maybe I'm a little bit maybe spoiled because I'm a CT operator, so I'm usually operating with microcatheters, and I think that's why I jumped to that version a little bit earlier. It's not recommended, and you can actually, as I said before, get distal thrombus out with not being there with your aspiration catheter, being a little bit more proximal.
And you also showed that there was residual thrombus, right? I think
Yes.
it is important to mention that you do not have to clean the arteries completely. Stopping is, as always, most difficult, right, when we're doing interventions. But here it is so. At a certain point in time, when you see improvements in hemodynamics, you can stop. And you don't need to clean the smallest peripheral segment of the vasculature free of thrombus. I think that's right, and that's
Absolutely
what you're doing.
right. Yeah.
Okay.
We just didn't have improvement until there, and then so that's why I went on. Second question was blood loss. Yes, in the beginning was a little bit worrisome because those aspiration syringes are 70 cc. That's how much they aspirate at once. And once you've aspirated like 5 or 6 of them, you think that's quite a lot of blood. And now Inari helped us as well because they have flow saver. It's basically a small cell saver without all the power thing and nobody to run it. It's that big. It's just a cloth inside, and it has 2 connectors. You put your aspiration syringe and you put everything through that clot, so the blood gets cleaned out from clots and bigger particles. And then on the other side, you have a 50 cc syringe, and you can give it back right into the pulmonary circulatory. So that's really helpful, and you can have longer procedures, and you don't have to be worried if your first 2 or 3 suctions bring nothing abroad.
That's difficult. Thank you very much, Gregor. So we're getting more and more questions, which is great. We'll address those questions after the next case presentation, and Karin Thoma will now show us a patient he has treated with high-risk PE.
Thanks for having me. So it's great to see the interest in the PE space, how it evolved from even a couple of years ago. So our case is again a 54-year-old gentleman. So it's a disease of young people, diabetic, hypertensive. No prior history of VTE. Comes with 8 days prior to this presentation. He underwent a nephrostomy and lithotripsy, basically, for his kidney stones. He had a little bit of bleeding, but he went home. And now he comes back with abdominal pain and has opioid-induced constipation, and he gets admitted for that. So he's getting a little bit better, but during physical therapy, he has a syncope. He passes out. They do brief CPR, just a couple of minutes of CPR. They get return of spontaneous circulation. Patient is diaphoretic and tachycardic and appears in distress and gets intubated. This is his EKG, okay, and the automatic reading of this EKG reads as STEMI. So this automatically triggers a STEMI alert. Obviously, this doesn't look like a STEMI. This looks like a very acute PE with RV strain and a acute right bundle branch block. There's no concordant STT wave changes here. So he goes to the cath lab. So this is a patient that's sick with what appears to be, obviously you'll see it's a massive PE, makes it to the cath lab, gets clean course and returns to the ICU, and a CT is recommended. Again, this is at a hospital. It's not at our hospital. It's a satellite hospital that has CT surgery, has a PERT team, has all the technology available. They do a bedside echo, shows RV dysfunction. I'll show you that in a second. And this is the decision point. What do you do now? You give TPA, you put the patient on ECMO, he's on one pressor now. You take him back to do that CT that the cardiologist recommended, or you do CDL or thrombectomy. And we can stop here, or we can continue discussing, we'll continue the presentation, but if you look, this is the official sort of absolute contraindication to systemic lysis and relative contraindication to systemic lysis, and you can see that he has a relative contraindication in that he had a recent invasive procedure. Unfortunately, the PERT team doesn't get consulted here, and the intensivist on call decides to give the patient TPA. Post-infusion of TPA, the patient goes into cardiac arrest, requires CPR, pressure escalation, ends up being placed on ECMO at bedside. He's gushing blood from every tube he has, basically. The heparin gets put on call, gets transfused, ends up going to the EIR. So again, this patient makes it to an interventional suite twice already, and gets coiling of the renal artery. At this point, he gets a decision is made. We have a shock team that we consulted, that we discussed. We decided to transfer the patient to UPMC Presbyterian, which is where I work. So he comes, and at this point, he hasn't even had a CT yet. So this is his CT, and I'll see if I can maybe pause this and show you the relevant findings. You can see on the right side here, right at the bifurcation between the truncus anterior and the interlobar artery, there's a lot of clot. And there's also distal clot on the left side that you can appreciate here. Now, what's impressive here is how much blood he has in his abdomen. I mean, his lungs are completely compressed by how much blood he lost, basically. He got transfused about 36 units of blood from the TPA. So a young guy who gets TPA, right? So what do you do now? You continue ECMO support and see what happens, basically, and a lot of centers do that. Once you put a patient with PE on ECMO, you just leave them on ECMO and intervene only if they deteriorate, or you send them to an operation, or you do thrombectomy or CDL. Our approach is that everybody gets put on ECMO for a massive PE, gets automatic thrombectomy within 24 hours. There's no point in letting this patient sit on ECMO for 2 or 3 or 4 or 5 days, developing complications from ECMO support, vascular complications and whatnot. If you made the effort to save somebody with ECMO, just go ahead and take care of the problem. This is the family of devices that we talked about. This is the new Triva device, the new FlowTriva device, the FT2. The catheters are actually called Trivers, and this is the blood-saving device that we talked about before. And I'm not going to show you a lot of the procedural steps because we don't take a lot of pictures in these cases, but look how compressed this lung is. I mean, normally these vessels, speaking of Irene's point, this is not because of the BMI, but this is because of the fact that there's so much blood in the abdomen here, compressing the lung, essentially. So the way we do this, we position the wire, we verify where we place that stiff wire, and that's very important because you want to have a relatively big vessel where you place your wire. You go with the T24. You do an aspiration kind of where that bifurcation is between the TA, the truncus anterior, and the interlobar. That's the sweet spot where you almost always get a clot from. And in this case, we also went into like you saw in the other case as well, we went into the truncus because, again, this guy's superior lobe is very important for his physiology, given the fact that the inferior lobe is completely collapsed, essentially. So 6 total pulls, 2 in the IL and 4 in the IL and 2 in the truncus. Then we move to the other side, and here you can see how the clot on the left side actually usually gets deeper, and it's draped upon the A10 and A9, probably bifurcation, or A10 on A8. And it's a little harder to get to this. There was some proximal clot there that we took with the T24, but then we went with the T20 curve. And again, to Irene's point, this is not where the aspiration was. The aspiration was done a little more distal, and we took that clot out. And what's important, the discussion is when do you stop, right? How do you know these patients are doing better? I mean, you can look at all these pictures and take all this clot out, And we thought that that's very important, and of course it's important to take clot out, but my important thing is the hemodynamics. How do these patients do? So the PA pressure in this patient went from 52 to 37. This is with the ECMO circuit clamped off, so we can actually get native function. Of course, you can't do a cardiac output here, so we didn't have that. Heart rate went from 111 to 85. Blood pressure went from 92 to 126. We took him off pressors, or maybe he was just on one pressor. And of course, this is the usual clot pictures. So 3 days later, he gets off ECMO. I think he could have come off ECMO earlier, but it was the weekend. This is his echo at day 3 when he gets, decannulated. Long hospitalization, obviously, because of all the bleeding problems that he had and developed neuropathy and whatnot, but ends up going to rehab, and he's doing well. So this is our algorithm, and I think what we learn based on the data that we actually have now is that when you have a massive PE, and this case illustrates that, when you have a massive PE with hemodynamic instability, the first question we ask is not, should we give this patient TPA? The first question we ask is, can this patient go to the cath lab? And if the answer to that question is yes, then that's what you do. You go to the cath lab and get mechanical thrombectomy. So this is not just for high-risk patients, high risk of bleeding, or older elderly patient post-op. Everybody gets this. The other important thing that I want to illustrate with this case is this ECMO issue. If you get put on ECMO, automatic thrombectomy in 24 hours. So you can get the patient along the healing pathway and get them off ECMO. This is our intermediate high pathway, but I'm not going to touch on that. So with that, thank you for your attention.
Thank you. We have a lot of questions from the audience, and we'll just start with the first. What about anticoagulation during the procedure, like heparin? Which ACT are you shooting for?
Yeah, so we want all the patients to get low molecular weight heparin in the ED because that kicks in much faster. And we keep an ACT 200 to 250, basically. And we give heparin on top of that. We never have any problems with, we pre-close this now with 1 per close or 2 per closes.
That's another question, yeah. So how do you close the access site?
Yeah, just pre-close it.
2 or 1?
2. Yeah.
Okay. We use 1, which is in most cases also sufficient. Another question is coming from the audience related to the use of small doses of fibrinolytics locally. Do you do that in addition to mechanical thrombectomy for the residual thrombus, presumably? That was the question.
We don't that much. I mean, to be honest with you, I can't think of a situation where I did that. I'm a little concerned about the large bore access if we give TPA on top of this. So that's probably one of the reasons why it steers me the other way.
Yeah. Many other very relevant questions. Maybe one, do you always check by Doppler the legs, saying that you might have residual thrombus, and then you select the groin according to the Doppler?
Yeah, absolutely. So residual DVT is a risk factor for badness. Basically, if you have residual DVT, chances are you may have another event and die from the second event. So we do look at that, and we try to, obviously even in the cath lab when we get access, it's ultrasound-guided access, but it's not necessarily just to make sure you hit the vein, it's to make sure that you don't have clot there. It's very easy to see.
Gregor and Irene too, and Pablo, procedural time. So in your practice, we have seen now, I think, selected cases, of course, but on average, how long does it take to complete such a procedure in your practice?
1.5, 2 hours. I was a little bit shocked when you presented the data, 35 minutes. We have to speed up a little bit, but I mean, from patient getting in the cath lab until he or she leaves the cath lab, it's about 1.5 hours.
Okay. Irene?
Yeah, probably an hour, depending on how you define the procedure length, from stitch to close, probably 50 minutes, and in unlucky cases, probably double. You may take longer.
So I agree in the way that if you're an academic center, and from the moment you take the patient in, you do a full heart cath, and then you do the procedure, maybe you're teaching somebody, and then you want to end the procedure and take the patient off, it's going to be 2 hours. But if you really want to rush and you are an experienced operator, you can do this in 45 minutes. The only comment that I would like to make is that you should not make shortcuts when using these devices. So this device is very safe. You could see 1.8 complication rate in very similar numbers in European and US centers. But this is why, because you always go over the wire. You never move the catheter around without a wire. You always advance the dilator to avoid the razor effect of advancing the the catheter. So you have to do every step every time the same way to avoid complications, because the device is large and obviously you could risk a perforation. So you really don't want to rush. Take your time and do the steps.
Yeah, I agree. Usually it's about 1 hour in very challenging anatomy, and but I think the key point is exactly what you said, Felix. It's not to try to clean everything, because you might have more complication than success, I think, in this case. Maybe last question, which venous access would you prefer? You say that you always go right femoral unless you find some residual DVT in the Doppler?
Yeah, then you would go left. I mean, there's some of it's been done from the neck, but it's, as you can imagine, it's a very painful approach. So.
No, I think start femoral, really.
Maybe also one comment on shortcuts.
Yes,
it's really a procedure where you should never take shortcuts, also not on the material.
Yeah.
And I can explain from my own experience. The first case, I was really eager to do this first case, and we were lacking this Amplatz super stiff wire, which is absolutely necessary, and you have to put it in the way I explained previously. And I said, yeah, we have extra support wires, and I know how to handle them. And it's just not the same. And I had a distal vessel perf, which was with wire, and I could solve it with reverting ACT, but it's not something you want to have and you should have in this scenario. So it's really crucial to take all the material what the company gives you and tells you.
Okay, that's great. I think we will now move. So it's good that we've seen the evidence, we've seen cases, one intermediate risk and one high risk. And maybe now, Pablo, you can share with us a proposition of algorithm to see how to implement this technique in the PE network.
Thank you. This
and I think for you, that's probably the most interesting part. So please don't leave the room.
Yeah, this is just bringing down the theoreticals to what you should do in the cath lab. So I'm just bringing what we do. This is the status quo. So the guideline recommendation should be considered in contraindication of failed thrombolysis and in intermediate to high risk and alternative if you happen to have hemodynamic deterioration. What do we do at Madrid Clínico San Carlos Hospital? We do not wait. So provided you have a proximal thrombus and the patient has an intermediate to high risk PE, what we do is we admit the patient in the acute coronary care unit, and we monitor the patient for 24 hours. And we look at primary drivers for elective with an emphasis on elective. So we are not waiting for the patient to deteriorate, but we have a lot of evidence supporting that this patient will have over 10% mortality. And I think this is just not acceptable. We will not be accepting maybe a non-STEMI with 10% mortality. So in an intermediate to high risk PE that has a positive lactate and shock index, meaning heart rate over systolic blood pressure over 1, or syncope, there is strong data that supports that this patient convey 10% mortality. And with mechanical thrombectomy, we know the numbers. We know we can lower down those numbers to 1-2% of mortality. So we go electively to the cath lab. And I write here mechanical thrombectomy, but should you have any other kind of catheter-directed intervention, meaning local thrombolysis, this could be acceptable as well. And if we don't have any of these primary thrombectomy criteria, we will move for the second ones, which will be a really big thrombus burden, saddle thrombus, and then severe RV dysfunction, deoxygenation, or proximal DVT. If not, we will just wait, monitor this patient 24 hours, 36 hours, and if everything is all right, go to the ward. What do we do with high-risk patients? We take the contraindication for thrombolysis criteria to send the patients for mechanical thrombectomy, and also we add the high bleeding risk. So these are patients that usually are undertreated. They should undergo systemic thrombolysis, but the doctor is afraid that the patient is going to bleed. And we also have predictors of this, which is the BAX score is bleeding, age over 75, cancer, syncope, coagulopathy, or low body weight, meaning less than 50 kilograms. If we have a patient like this, we go straight forward to mechanical thrombectomy. If not, we will give systemic thrombolysis / ECMO. We will monitor the result of this systemic thrombolysis in the very early hours, 2 to 4 hours. This is coming from the recommendation of the consensus paper from the ESC. And if there is no clear improvement, we move forward fastly, the same way as Kathleen commented, to mechanical thrombectomy with or without ECMO, depending on the critical situation. This is the whole algorithm for the algorithm lovers, and I'm open for discussion with the panel and with you. Please stand up and comment.
So do you have any question? Yeah, maybe one question, Pablo. You say that you try to do mechanical thrombectomy for this kind of patients. So what is the organization within the team? I mean, all the interventional cardiologists are able to do this kind of procedure in your team in Madrid, or you have dedicated on-call list for pulmonary embolism? How it's organized?
So at the moment, there is no specific, so there is no like primary PCI and pulmonary separate calls. But we are about probably to make it, because in the Madrid region, which is 7 million inhabitants, we already set in place a regional program where 7 hospitals will receive each one referrals from 1 million inhabitants. So probably we will have to move towards that, because the patient referral is going to probably increase. But at the moment, what we do is intermediate to high risk, very as an analogy, very similar to the non-STEMI patients. So we admit the patient, we monitor, we select them for therapy, but the therapy will be done in the next first thing in the morning, so 24-hour basis. And for the high risk, just for the high risk, we have to be on call. I'm probably doing more procedures than my fellows.
Even Saturday, Sunday, the patient coming Saturday afternoon, you will do on Sunday?
Yes.
Yeah. No, but that's important question, I think,
yes,
for
because Friday to Monday is too long.
So any thoughts on CT parameters or evaluation of CT imaging in general that help you decide that is a good candidate for thrombectomy?
So we normally spare the patients with just segmentary artery thrombus burden, because it's probably not so important. You should take care of addressing the acute on chronic. That is very dangerous, probably a no-go for mechanical thrombectomy if you clearly identify a patient with very high pulmonary artery pressures. Maybe Katalin is doing some research on that and could expand on the CT evaluation, because I think it's very important.
Yeah, I think this is going to be a very important topic, and we all struggle with these cases where you take them to the lab and you realize this is actually very chronic, and So now you sort of back engineering this and looking at the CTs and try to understand what was that made that thing look more chronic, and it's the way the clot looks, the angle. The acute clot is in the middle of the vessel. The chronic clot is adherent to the side of the vessel, so that's the angle between the vessel and the clot. If it's chronic, if it's acute, is acute. And then you're looking at the PA pressure. You can look at collaterals, which is very hard to find for a non-radiologist, and RVH and things of that nature that would predict that this patient has, and of course, a history of PEs in the past. So, but that's an important thing. This is why, if you do this, you need to learn how to look at the CTs yourself and not rely on the radiologist alone.
What's the pulmonary pressure cutoff you take? Because many times when we take the patient, the pressures are quite high, 70 PA systolic, mean of 35-40. Should we take up these patients for this, or wait, or
not the first patient that you do. But having said that, if we look at the flash data, even the patients who had high PA pressures benefited, because a lot of times it's acute on chronic, so you do get a little bit of benefit from that. But it's a more tenuous situation.
And will you use the disc in this kind of patient when sometimes the clot is really against the wall and you want to make it easier to retract the thrombus?
Yeah, well, that's a theoretical consideration, because the first generation of discs did not perform as well as the new one has a little bit more scraping capacity. But if the clot is adherent, this clots become adherent very quickly. This is not a thing that you realize doing this. It doesn't take months for this to stick to the vessel wall. It takes days to start sticking to the
there's
vessel.
no pressure threshold. You can have 80 millimeter mercury on an acute PE still on echo. But as Katalin said, be cautious and don't do it as your first case. Doesn't mean CTEF. CTEF is much more complex. You have to look at the CT scans and all the secondary signs.
Final, very brief question, and we'll try to get a brief answer.
Yes, sir. So, for example, when we do these large bore thrombectomies, we use the separator for all the patients so that we remove the adherent clot. Will it be helpful in a lot of cases, because they are quite expensive in a developing country like us? When we do the mechanical thrombectomy with the penumbra, with a large bore, and We have got the.
That's a different separator. I mean, like an intermediate bore catheter will not dislodge anything off the vessel wall. I mean, that's 100% sure.
Okay, let me conclude by saying thank you. Thank you for coming to this session. Thank you for discussing the evidence around PE treatment with mechanical thrombectomy, the unmet need that exists, and the opportunities that we have at hand with these new devices. Evidence is pressing on, and we'll see much more of this. Stay tuned and enjoy EuroPCR. Thank you very much.